apart from hereditary diffuse gastric cancer and gastric adenocarcinoma with gastric polyposis,
zoom it.
the other things have
Zoom करिए ना
made it
डॉक्टर
into.
राकेश.
So, apart from those two, it's Lynch, FAB, then Li-Fraumeni, Peutz-Jeghers, juvenile polyposis syndrome, hereditary breast and ovarian cancer, P10 hamartoma, that's Cowden syndrome, and ataxia-telangiectasia. So in this syndromes also, there is gastric malignancy incidence. So starting with the major, that's hereditary diffuse gastric cancer and familial intestinal gastric cancer. So by this syndrome, gene mutation is CDH1, autosomal dominant inheritance. They have a risk of 70 to 80% of developing gastric cancer in their lifetime. By histology, it is diffuse gastric adenocarcinoma, and associated malignancies. There's lobular breast cancer. So here, histological clues are in mucosal foci, there will be in situ signet cells if it is not yet formed invasive carcinoma, and abnormal EK-adherent immunostaining. So in clinical clues, familial clustering of gastric cancers, lobular breast carcinoma, young age of onset, and association with cleft lip and palate. So in hereditary diffuse gastric cancer, which is associated with CTNNA1 gene mutation, which is autosomal dominant, unknown lifetime risk with diffuse histology, no other associated malignancies noted, and here abnormal E-catenin immunostaining and younger onset and familial clustering is known. So if it is associated with intestinal type of gastric cancer, it is familial intestinal gastric cancer, autosomal dominant. Here, familial clustering without polyposis. Next. So, what are the criteria?
थोड़ा और zoom करो.
Hereditary gastric cancer updated to. So, by age, we have to remember two numbers, 40 years, 50 years. And in familial history, there should be 2 cases, out of which one should be diagnosed as diffuse gastric cancer by histology. Then, if there is personal history of diffuse gastric cancer, such people should be less than 40 years. So, if you have 50 years age, then it will be personal or family history of first or second degree relative with diffuse type of gastric cancer and lobular cancer, breast cancer, and one diagnosed before 50 years. So what are the other supporting criteria? Families with bilateral or multiple cases of lobular breast cancer before 50 years, families with clustering diffuse gastric cancer and cleft lip and palate, or any patient that is diagnosed with in situ signet ring cells or vegetoid spread of signet cells. In for criteria of familial intestinal type of gastric cancer, Rakesh, just move the document. No? Yeah. Here, 2 or more documented cases of intestinal gastric cancer, first or second degree relative with at least one diagnosed less than 50 years, or 3 or more cases of intestinal type of gastric cancer in first and second degree relative independent of age. So if you have 2, age cutoff of 50. If 3, there is no age bar. So next, this is duplicated. So next, down. So there'll be, excuse me. So clinical management is you identify patients and families at risk of developing this diffuse type of hereditary diffuse gastric cancer who fulfill the clinical criteria and may exhibit any other associated related features like cleft lip palate or lobular breast cancer. Genetic testing to identify the causative germ defect. It can be CDH1 mutations or deletions or CTNNA1 mutation. integration in a program for risk assessment and reduction measures. So what do we do? And identify CDH1 germline mutation carriers for diffuse gastric cancer prevention. Risk reduction gastrectomy is indicated. That is the primary option you give. In case they say no, then surveillance with gastroscopy with multiple biopsy, though it is controversial. In lobular breast cancer prevention, risk reduction by bilateral surveillance from age of 30 with MRI and surgery to remove early lesions are indicated. However, prophylactic mastectomy is controversial. So there's another entity which comes in syndromic gastric cancer, that is gastric adenocarcinoma and proximal polyposis of stomach, GAPS. It's a new autosomal syndrome. Here, mutations, that is APC, MUTYH, CDH1, SMAD4, BMPR1A, STK11, P10 has to be excluded. Then the spectrum of the disease has next. So along the So along the APC gene, this one. So from 5' to 3' in different axons, the predisposition to a particular organ or system is replicated on this diagram. So at the 5' end, at axon 1A, so stomach is a single target where GAPS is phenotypically manifested. So if you go at exon 15, it is colon is the main target. At 3' end, it's attenuated fab with colon and stomach. Next, so here exon 1A. So this syndrome has mutation. It's a point mutation in exon 1B of APC. It's autosomal dominant. It has got fundal gland polyps, few hyperplastic polyps and adenomas. So there is increased risk of gastric malignancy. By histology, it can be intestinal and mixed. Here, fundal gland polyposis with antral sparing. Important clinical clues is gastric polyposis. Here, colorectal polyposis has to be ruled out and without any use of chronic acid suppression therapy. So, attenuated familial adiposis polyposis, that is FAP, APC gene mutation, autosomal dominant. Here we have predominantly fundal gland polyps, foveolar adenomas and pyloric gland adenomas. There is no association with increased risk of gastric malignancy in the lifetime. Associated with gastric cancer histology, that is intestinal, fundic gland polyps. Then here the other associated malignancies can happen in colorectum, thyroid, duodenum, adrenal, small bowel and brain. So here there are along with the gastric fundic polyps, there is colorectal and duodenal polyposis. So for GAPS, you have to rule out colorectal polyposis. So what's the essential criteria? Phenotypically proximal, body and stomach, antral sparing, more than 100 polyps, and predominantly fundic gland. Here you have to, so the proband or the family member with either dysplastic familial gastric polyposis or gastric adenocarcinoma, mutation in APC chromosome 5 at promoter 1B exon. Supporting criteria, there should be family history and spectrum of other histological lesions that we already saw in the stomach at various types of polyps. Next. So in couple of coming slides, if they ask risk factors for gastric adenocarcinoma, so we can divide it as environmental, genetic and host factor. Genetic, more or less, we have described already. So this is the environmental risk factors: cigarette, alcohol, H. pylori infection, dietary factors, radiation and low socioeconomic class. Next. So here pictorially they have represented how H. pylori causes or is associated risk factor for increased malignancy. Same thing, I've just pictorially represented that there will be inflammation. And so here the same thing, there will be replication of H. pylori that will induce gastritis, there will be inflammation. They will cause reactive oxygen species. Now the supporting cells that is replicating will get exposed to this reactive oxygen species 1. And severe superficial gastritis, there's multifocal atrophic gastritis and intestinal metaplasia that leads to a condition achlorhydria, which favors bacterial overgrowth, which generate carcinogen through nitrosation of dietary amines. Next. So, dietary factors: smoked food, high intake of salt and pickled raw vegetable, high intake of carcinogens like nitrates in food, drinking water, nitrites in preservatives, tobacco smoke, juice, or consumption of alcohol. Protective is green leafy vegetables, citrus fruits, and animal fat. Next. So here, some of the syndromes we already saw. Associated genetic factors can be blood group A and other inherited polymorphisms interacting with environmental factors that we can add. So, yeah, this is what we already discussed. Diffuse type and intestinal type, both can be familial. And how CDH1 and CTNNA1 is associated with diffuse gastric and rest is intestinal. Next. So how partial gastrectomy and other predisposing lesions that will increase bile acid reflux, increase alkalinity, and thus increasing gastric carcinoma risk. Next, it is depicted pictorially. Next, the same way. And these are syndromic, we have already discussed. By host factors, again, all this gastric ulcer, autoimmune gastritis, multifocal atrophic gastritis, and intestinal metaplasia and dysplasia. Next. Coming to various classifications. So if they ask about classifications in stomach, one, there are different subheadings under which you can. So histologically broader, Lauren broadly said intestinal, diffuse, and intermediate type. WHO 2019, I think, yeah. Newer classification is adenocarcinoma, and which has papillary tubular mucinous, poorly cohesive types in that signet cell carcinoma. There's mixed variety, adenosquamous, squamous cell, and other named pattern of malignancy. This is under WHO. So by molecular classification, there are two schools, that is Genomic Atlas TCGA and Asian group of I think ACRG is Asian Cancer Research Group, if I'm not wrong. So they have given similar classification based on molecular. So each one is written side by side. They have similarity. So it is EBV associated, and there are characteristic underneath. So EBV is equivalent to ACRG MSS, in which P53 is positive. Here there is intact P53 activity. There is EBV infection. It is intestinal subtype with intermediate prognosis. Coming to MSI high, here hypermutation, there will be a lot of inflammation. It is good prognosis, intestinal type, and it is best of the prognosis. In genomic stable, here younger patient diffuse type. Thus, it is worse prognosis. Here, it is epithelial mesenchymal transition is present, translated by CDH1 loss expression. Then chromosomal unstable type. Here, P53 loss is there. There's genomic instability, and thus it's got intermediate prognosis. So these are the two molecular. So next, coming to, this is elaborated, the same thing. Then by histology, intestinal type and diffuse. Diffuse type is poor. Like there is familial association with type A, female predominant, young age, poorly differentiated. It is by transmural or lymphatic peritoneal dissemination, loss of EK adherent, so poorly or discohesive cells, ulcerated lesion, intraperitoneal mets, and linitis plastica. Everything good is in the intestinal type, where there is atrophy, intestinal metaplasia, male predominance, older age group predilection, gland forming cells. So there is more differentiation, hematogenous spread, microsatellite instability, APCG mutation, exophytic and bulky lesion. So these are the two by histology. Then by endoscopy in advanced malignancy, there are these type of protruding, here depressed excavating. So first is protruding, it is polypoid. Next is ulcerative type 2, ulceration with infiltration, diffuse infiltration, and typhoid cannot be classified. So this is by endoscopy. Early cancers are by Japanese classification, and advanced is by Boardman's classification. Next, coming to Japanese. So here it is protruding, superficial elevated, flat, superficial depressed, or excavated. So we'll start with type 0, then 1, 2A, 2B, 3C, and 2C and 3. So this is for Japanese early. So these I've just put the WHO in case you want to go in detail. Then again, anatomical classification. No, you have to go down. I might have missed, I think. Down, still. Yeah, anatomical classification is, we can write cardia and non-cardia. So because there is separate classification, so we can write this and again write about C words and others. Then we'll have to add TNM staging and classification. Here even prognostic staging also can be added. And for treatment and prognosis, we divide it into early, advanced, and metastatic. So below, there's an algorithm. I don't know if I put it here. So this is the thing. When we said early, locally advanced, and metastatic. So briefly, how we can address this by endoscopy or limited resection, or we go with different types of gastrectomy with lymphadenectomy. For stage 4, that is metastatic setting, systemic therapy, that we'll have to write. That's it. Next is HIPEC. I'm preparing it. I have not. This is trials in HIPEC. I have to still do. Trials in gastric cancers with role of CRS and HIPEC.
Okay. पढ़ाइए.
Hello. Okay, so mostly retrospective studies and do not use objective criteria to define assess the dysphagia. मतलब dysphagia के अलग-अलग वो criteria हैं जो अपन scoring वगैरह वो एक अलग topic करके किसी दिन पढ़ा दूँगा. Then options for palliation are stents, feeding tubes, chemotherapy, EBRT or brachy, और कॉम्बिनेशन. सो ऐसा कुछ नहीं है कि कौन सा बेटर कौन सा क्या, मोस्टली फिजिशियन प्रेफरेंस पे है क्योंकि मल्टी फैक्टोरियल है, काफी फैक्टर लग के डिसीजन बनता है. फिर भी बेसिकली अपन कंपेयर करेंगे तो आरटी अलोन वर्सेस कीमो प्लस माइनस कीमोथेरेपी. सो देयर इज नो डिफरेंस इन डिस्फेजिया रिस्पांस और क्वालिटी ऑफ लाइफ मेजर्स. सिग्निफिकेंट इंक्रीज इन जीआई टॉक्सिसिटी विद कीमो रेडिएशन. दैट इज फ्रॉम TROG 0301 trial. Then second option is self-expanding metallic stents plus RT. So no benefit by adding RT in terms of time to first complication and re-intervention.
क्या हो गया? म्यूट. चलो. राकेश ही म्यूट हो गया क्या?
नहीं मैंने म्यूट किया है।
सॉरी
किसका था वो?
फिर पता नहीं किसका था, मैं तो तुम दोनों को करके आया था। ओके, तो मेटालिक स्टेंट्स प्लस आरटी, तो आरटी ऐड करने का कोई बेनिफिट नहीं था स्पेसिफिक to decrease the bleeding risk and need for associated interventions. So should be reserved for patients at high risk of bleeding. अगर अपने को लग रहा है कि हाई रिस्क ऑफ ब्लीडिंग है तो साथ में आरटी भी दे सकते हैं. Then stent versus endoluminal brachy. Dysphagia improved more rapidly after stenting. However, long-term relief superior with brachy. Reference is Dutch IREX study group. Article is there. Major limitation of brachy is effective treatment distance. Any portion of tumor more than 1 centimeter from the source will receive suboptimal dose. Primarily used isotope was iridium-192. So no difference in local control or survival with HDR brachy versus STR brachy with EBRT. If EBRT is not possible due to prior RT, endoluminal brachy should be considered because it is effective modality for decreasing symptoms such as dysphagia and bleeding. So if patient has received RT, EBRT before, then we can consider for brachy. If a patient requires rapid palliation within a few days, then laser treatment or stent placement are recommended. Then EBRT with without chemotherapy takes at least 2 weeks to produce the palliation. Once palliation is achieved, it is more durable than other modalities because EBRT treats gross tumor mass as well. Chemotherapy by itself may also substantially relieve dysphagia when used as initial treatment of metastatic disease, but it takes longer. So if we need rapid relief, then we can use either laser or stent, and if patient is able to eat something, then impending dysphagia is suspected, then we can better start on chemoradiation. Now, TOF, though there is no question asked, but as it was associated, I just included 3-4 lines. So in setting of TOF, as we generally know, radiation is avoided, and it is also given in NCCN guidelines. But presence of malignant TOF, does it outline neglect every time we can avoid the radiation, or there are some cases that we can give radiation? So presence of malignant TOF usually results in poor survival, although occasionally